Pain in the face is not nice. Hurts is not nice. Pain in the face. For so many reasons, this looks that he has pain in the feet. This looks that he has pain in the frontal air sinus. It's pointing at pain coming from ethmoidal air sinus. It's pain in the eyes. This is headache. This is a case of deviation of the mandible. The mandible is deviating to the right. Again, this person, whenever he opens his mouth, the jaw goes to the right. Same thing. Last something called trigeminal neuralgia. All these complaints are conveyed. All these pains are conveyed by something called trigeminal nerve supply of the face. There's this medical case where you cannot see something visible on the patient. The patient comes and tells you the story, you have to believe him or her. It's called trigeminal neuralgia. You will be facing this in the near future. It is also called tic douloureux. It comes as attacks of stabbing unilateral facial pain. Stabbing as if somebody is stabbing a person with a knife. It's like lightning in the face. Along the distribution of one or more of the trigeminal nerve divisions, usually the maxillary. And the pain is paroxysmal, comes suddenly and goes suddenly, lasting seconds or up to 2 minutes. And attacks may recur rapidly. Nothing visible, nothing in the physical finding. Therefore, remember that we learn more and apply. This is the story of what we are involved in. We learn and then we apply. It's like when we get a machine or a gadget, we read instructions and then we go and apply. It's the same process. Therefore, we must be professional. General knowledge is not enough to treat people. You cannot treat people with general knowledge. Okay, trigeminal nerve supplies the face. Thank you. No, that's not good enough. It is not general knowledge. That's what we need. And what you are learning here is knowledge for life. Nobody is going to talk to you about the trigeminal nerve. Everybody, by the end of this lecture, is going to ask you about applying this knowledge. So what we need here is knowledge for life. And it's up to you. You would like your knowledge to be built like this or like this. Always ask yourself, is my knowledge sound enough? Can I face patients? Can I face people? Can I face exams? If your knowledge is like this, don't worry. If it is like this, you'll start begging for marks. So what is going on? We need to know because we care. Doctors usually, ethically, should care about patients. And story of what we do, where, when, how, what, and why. This is the general plan of trigeminal nerve. There's this element coming out of the brain, it's around the eye, and goes over the forehead. Therefore, this is going to be called ophthalmic. This element here is going to be related to what is inferior to the eye, which is the maxilla. Therefore, it's going to be the maxillary part. And this part of trigeminal is related to the mandible. Therefore, it's going to be called mandibular division. Okay. This has a ganglia, and this one has a ganglia as well. So we have two parasympathetic ganglia related to the trigeminal. So we know now that there is something called ophthalmic, maxillary, mandibular. Trigeminal nerve is the largest. Most complex cranial nerve. On the opposite of that is, for example, abducing nerve. It's the simplest. One nerve for one muscle. No sensory supply. Now, this face of this person is colored, shows sensations of the skin covered by B1. B1 is the cranial nerve number 5, first division, which is ophthalmic. B2, second division, which is the maxillary, and the third is the mandibular. Starting point is what? It's the brainstem. Level of spirocurriculus, starting of this part of the nucleus, which is called mesencephalic nucleus. Then you go lower down at the level of the bones, and you have this part of the nucleus, which is called the main sensory nucleus, or also called pontine nucleus. And then a long extension along the lower part of the bones, medulla, and even spinal cord. This is called the spinal nucleus of trigeminal. All these are sensory. Plus this nucleus, it's the motor nucleus, and it's going to supply muscles of mastication. So the bulk is sensory to the face and deep structures of the face, the eye, sinuses, mouth, and the motor part is a minor part supplying muscles of mastication. The uppermost part, the mesencephalic nucleus, then the pontine main sensory nucleus, and the spinal nucleus. Now, sensations will go through the 3 divisions into the brain. The spinal nucleus is concerned with pain and temperature. Toothache, pain in the face, is felt in the spinal nucleus. The main sensory nucleus is concerned with pleasant sensation. Touching your face, putting ice cream on your tongue, chocolate. These are nice sensations that are felt here. The mesencephalic nucleus is for proprioception. This mesencephalic nucleus is strange because it has the first organ neuron cell body. It should be outside the brain. But in this case, it is inside the brain. You know, proprioception is sensation of position of muscles. motor part, the absence of these neurons, they go only to B3, the mandibular, for muscles of mastication. Discriminative type. How is it projected on the brain? Input from the mouth, for example, felt by B2 and B3, goes to the dorsal, the trigeminal thalamic tract, and crosses to the other side, goes to the medial lemniscus, and the pain and temperature comes from the three divisions: pain in the eye, pain in the sinuses, pain in the teeth. This pain is going, of course, to the spinal nucleus, and it crosses to the other side, goes up to the spinal lemniscus, to the ventro-medial-posterior part of the thalamus and the medial part, and then projected to the sensory area. Trigeminal nerve gets out of the brain on the sides of the bones and comes out as the main trunk and has its ganglia, because it's mostly sensory, therefore the cell body of the sensory neurons must be outside the brain. Here it is outside the brain, but inside the skull. And we have the ophthalmic, the maxillary, and the mandibular. The ganglia is at the tip of petrous part of the temporal bone. Ophthalmic goes superior orbital fissure, maxillary goes foramen rotundum, and mandibular goes to foramen ovale. Where are we? Here is the pituitary fossa, the orbital foramen or canal, and this is the middle cranial fossa, and the ganglion is in the middle cranial fossa. Here is an MRI showing you the trigeminal ganglia, which is a fairly good sized structure. This is the trigeminal ganglion, giving the ophthalmic, maxillary, and the mandibular. Trigeminal ganglia is also called Gazerian ganglia. It is in a cave called Nichols Cave. About 3/4 of it is bathed in CSF because it's in the subarachnoid space. The last part comes out into the subdural space. The motor part does not come and does not mix with the ganglia. It comes out separately. It is not part of the ganglia. People who like images, drawings, this is the ganglia giving the ophthalmic, the maxillary, and the mandibular. This is the pituitary fossa. This is pituitary gland, sphenoid air sinuses, and this is the cavernous sinus. This internal carotid artery inside the cavernous sinus. The ophthalmic and the maxillary are in the wall of the cavernous sinus. The mandibular is not. The because it goes lateral and down. The ophthalmic or D1 divides into 3 branches before entering the superior orbital fissure. And these are the lacrimal branch, because it goes towards the lacrimal gland. The frontal, because it goes and supplies skin over the frontal bone. And the nasociliary, because it's going to supply nose and the eyeball. Divides in the wall of the cavernous sinus and enters the orbit through the superior orbital fissure. This is the lacrimal, frontal, and nasociliary. Divides before entering the orbit. This is the roof of the orbit removed. The fat is dissected, and you can see this is the frontal nerve. Frontal nerve is going to divide into supraorbital and supratrochlear. The medial one is supratrochlear. The little bit flat orbital is supraorbital, supplying the forehead. Therefore, the origin of these 2 branches is called frontal nerve. This is the area supplied by the frontal nerve with its 2 branches, supratrochlear and supraorbital. Again, this is the roof of the orbit removed, and you can see this nerve going towards the lateral side of the orbit, towards a structure here which is the lacrimal gland. Therefore, this is called lacrimal nerve. That's the roof of the orbit removed. You can see the frontal nerve giving supraorbital, supratrochlear, and this is the nerve on the lateral side of the orbit. It's called the lacrimal nerve. These nerves, they enter the orbit, supply structures in the orbit, and then they go out of the orbit, supply skin around the orbit. This is the trochlea of the superior oblique, where it turns around. This nerve is the infratrochlear nerve, supplying the skin of this part of the nose. This is the supratrochlear, supplying the medial side of the forehead. Supraorbital nerve supplies the area of the eyebrows. The lacrimal is going to supply the area over the zygomatic bone, and the infraorbital is going to supply lower eyelid and area over the maxilla. This is blocking which nerve? Infratrochlear. This is blocking which nerve? Supraorbital. And this is blocking supratrochlear. This is blocking dorsal or superior nasal nerve. Again to the orbit. This nerve is crossing the optic, crossing laterally, going medial. الحضور الغياب الأخذ اللي بده يطلع مستر and Mrs. 10% الله معك. This nerve is going to supply the eyeball and the ethmoidal nerve sinuses and the nose. Therefore, it's called the nasociliary nerve. Can I call this lacrimal nerve? No, because lacrimal nerve runs on the lateral side of the orbit and it does not cross the optic nerve. Now, this nerve, as it crosses the optic nerve, is going to send these branches, several branches. They will go and enter the orbit, the eyeball. And because they supply the eyeball, they are called cilia. And because they are long, they are called long cilia. They bring pain from the eyeball. This nerve is going to carry forward and send a branch to the posterior ethmoidal nerve cells. The nerve is posterior ethmoidal nerve. Then goes forward and supply anterior ethmoidal cells. Anterior ethmoidal nerve. This anterior ethmoidal nerve, when it supplies the anterior ethmoidal cells, gets back into the skull through the cribriform plate and leaves the skull again to go to this structure here, which is the nose, called external nasal or dorsal nasal. Supplies the bridge to the tip. External nasal. This nasociliary is going to continue after giving all its branches, and it is going spinopalatine fossa has several openings. It's a wonderful distribution of nerves. There are 3 posterior, 1 inferior, 1 anterior, and 1 medial. Closer look at this area. This is the maxillary nerve, maxillary division. Crosses, and this is the pterygoid canal, where the greater superficial and deep petrosal nerves come here to feed the ganglion. The maxillary nerve is going to traverse, passes and travels through this fossa and enters the infraorbital fissure and canal and becomes the infraorbital nerve. That's the main trunk of the maxilla. In the floor of the orbit, it gives zygomatic branch, which is going to be to give zygomatical temporal and zygomatical fascia. In the pterygopalatine fossa, the maxillary is going to give a branch that enters this foramen and supplies the posterior teeth, upper teeth. This is called posterior superior alveolar. In the infraorbital fissure and canal, gives a branch to the upper teeth. It's the middle superior alveolar, and then the anterior superior alveolar. Sometimes the middle is not there. Now we go to the palatine part. To the hard palate is the greater palatine, the soft palate is the lesser palatine. Sphenopalatine foramen and the pharyngeal branches. The ganglion, posterior superior alveolar, middle superior alveolar, and anterior superior alveolar. This, if we zoom into this area here, this is the sphenopalatine ganglia, the parasympathetic. This is the maxillary, and it suspends this ganglia by 2 trunks, 2 nerves. We've seen the infraorbital fissure and canal. This arrow is doubled because it's in a canal and emerges as infraorbital nerve to supply the area here over the maxilla and the lower eyelid. This is the facial artery. It gives the zygomatic, which is going to give us zygomatical temporal and zygomatical fascia. The sphenopalatine, or the nasopalatine, is going to give branches to the nasal septum, superior, middle, and inferior nasal. And this is the pterygopalatine ganglia. This is the nerve of pterygoid canal. And these are the greater palatine nerve to the hard palate. And this is the lesser palatine nerve to the soft palate. These are the greater palatine, this is the lesser palatine. This blue arrow indicates the sphenopalatine, which is going to the upper 4 molars. This is the area supplied by the maxillary division. The root tip of the nose are supplied by the ophthalmic. The area here is by the dorsal or external nasal. The area here is supplied by infratrochlear and then supratrochlear. This area is going to be supplied by the infraorbital. This is the zygomatico-temporal being blocked. This is the zygomatico-facial, emerging from a tiny bony canal. This is the area supplied by the infraorbital of the maxillary. This is what the patient complains of. Where's the pain? Over the maxilla and upper lip. This is the infraorbital, showing that it's going to supply the lower eyelid. The upper eyelid is supplied by the ophthalmic. The lower is by the maxillary, the base of the nose, and the superior lip. This is the area supplied by the greater palatine over the hard palate. This is the end of supplying the four incisors. This is the end of the sphenoid. This is the area supplied by middle superior alveoli. And this is the area supplied by posterior superior alveoli. This is the area of the dentists. The maxillary is posterior, middle, and anterior superior alveolar nerves. This is what? This is touching with cotton the area supplied by the maxilla, which will end up in spinal or the pontine. Pleasant sensation. Now, the summary of the maxillary nerve communicates with the pterygopalatine ganglia after entering through the foramen rotundum and attaches to this ganglia by small trunks, pterygopalatine nerves, and the branches are infraorbital, you've seen this, zygomatic, zygomatico-temporal and facial, nasopalatine, you've seen this, superior alveolar nerves, pharyngeal nerves, and the palatine nerves, the greater and the lesser. Back to the middle cranial fossa. This is the main trunk of trigeminal nerve. This is trigeminal ganglion. This is the ophthalmic going through the wall of cavernous sinus, going to the superior orbital fissure. And this one here is the maxillary going through foramen rotundum. Now we will be looking into the mandibular going through foramen ovale. This is foramen ovale. Just posterior and lateral to it is foramen spinosum. This is the infratemporal fossa, which is medial to the ramus of the mandible. So all the images we see, what is going in the infratemporal fossa is that we have to cut the mandible. See what is deep. The mandibular nerve is getting into this infratemporal fossa through foramen ovale. It makes the roof. Is the ramus of the mandible. This is the pterygoid process, and this is the sphenoid, and this is foramen ovale. This is the main trunk of mandibular nerve, and this red structure is the motor part of trigeminal. The ophthalmic and the maxillary has no motor component. Motor component only goes for the muscles of mastication, and they are around the mandible. Therefore, the motor component will go with the mandibular. It is not mixed in the nerve. It comes as a separate tiny nerve. It mixes with the trunk into the infratemporal fossa. This is a posterior view of infratemporal fossa, showing the roof made of greater sphenoid where the foramen ovale is located. The lateral wall is the mandible, ramus of the mandible. Therefore, where in all images we see, and we want to see the infratemporal fossa, we have to cut the ramus of the mandible. And the medial wall is the pterygoid process. The infratemporal fossa contains arteries, veins, nerves, and muscles. The green one is called the lateral pterygoid. The red one is the medial pterygoid. Now, the motor is going to supply these muscles. Now, we saw patients with deviation of the mandible. It's the main function of the lateral pterygoid. So we have a right pterygoid and left pterygoid. If the left is not working, then the right pterygoid is working. Therefore, the jaw goes towards the affected side. This is the mandible cut, and this is the ear. And this is the main trunk of the mandibular division. This is the main trunk of mandibular division. This is foramen ovale. The main trunk comes in infratemporal fossa and divides into anterior and posterior divisions. Look into this situation. A nerve comes from the posterior division, goes posteriorly. The other component, they join together, and the middle meningeal artery goes into the foramen spinal fluid. This is a very special arrangement. The nerve arises from two roots and then becomes one. This is the auriculotemporal, and the artery goes between these two roots. This is the story of auriculotemporal nerve. These are deep temporal branches that will go to the temporalis muscle, which is the muscle of mastication. The auriculotemporal nerve, and you can see this arrangement of two roots, goes posteriorly and up to the posterior and anterior division, and it's going to supply the temporal area and this area here of the ear, the nerve area. And then we have this buccal nerve, which is going to supply the buccal area. This is sensitive. Motor is only for muscles of mastication. This is the lingual. goes to the tongue. This is inferior alveolar. Is going into the mandibular canal till reaching the mental frame and supplying teeth, and emerges as mental frame supplying the mental head. And then this nerve, before it goes into the inferior alveolar, before it goes into the mandibular canal, it gives a branch, motor, to the mylohyoid muscle. This is the lingual, and this is inferior alveolar. The motor part will come with the sensory inferior alveolar, and then it leaves the inferior alveolar to go to the mylohyoid. This black arrow is indicating the cardiac tampering, which we have talked about, sending taste to the facial nerve and bringing parasympathetic to the submandibular ganglia. Zoom to the main trunk, nerve to tensor tympani and tensor palatal, and to the medial pterygoid muscle. Deep temporal nerves, motor to the temporalis muscle, and when we reflect the whole arrangement, we're going to see the otic ganglion, receives preganglionic parasympathetic from glossopharyngeal, sending it to the parotid via the auriculotemporal nerve, which goes this way. The nerve which has two roots. That's the otic ganglion. This is the area supplied by the auriculotemporal, the buccal, and the inferior alveolar. The mental, passing cotton buds on the area supplied by the mandibular, testing that shuffle motor. Clench your mouth, testing the contraction of the cecum. Clench your mouth, testing contraction of temporalis. The jaw reflex. The jaw jerk. Put your finger, tap it, sudden, severe scratch of the cecum will result in contraction of the cecum, closing the mouth.